Hey, how's everyone doing? This is Dr. Matt Koepke. I want to give a huge shout out to Implant Compare, who gave me an opportunity to discuss a very fascinating subject called MRONJ, or Medication Related Osteonecrosis of the Jaw. I'm a young oral maxillofacial surgeon that just graduated from residency several months ago, so this is very exciting to be able to give this piece of information to a global network. So just a little bit about myself. So I grew up in West Virginia. So anyone who's outside the United States, this is near Washington, D.C., which is the capital of the United States. My father is a professor, so I ultimately went to West Virginia University to study physics. I then pursued a field in dentistry, which is another 4 years that you all know. And after those 4 years, I immediately knew that I wanted to pursue something more oral maxillofacial surgery. So I then traveled south, kind of closer to Florida if you're not familiar with the United States, and this is called the Medical University of South Carolina in Charleston. So this is where we spent 4 years of time learning facial reconstruction, becoming better at dentoalveolar, soft and hard tissue augmentation. But one of the interesting things that we did is we were exposed to medically compromised patients. And one of the things that we realized is that there's a huge issue with what's called medically related osteonecrosis of the jaw. And so this is what I want to bring to you all, because this is something that you may not have been exposed to because you didn't do an additional 4 years of residency. And frankly, this is all pretty new stuff. So just kind of a side note, so that's just me smiling because that's 2 months before I graduated, so you can imagine how happy I've been being out of school. So one of the things that I do on the side before I start is I do go to Haiti about twice a year to kind of give back. I think all of us who are part of this global network understand that we do need to give back, and that's one of the beautiful things about our field is we can actually help. So I'm excited to, one, spread the wealth of knowledge through Implant Compare, but also try to bring a global network together. So this is what we'll talk about today. So again, MRONJ, what is it and why is it important? So the acronym of MRONJ is Medication Related Osteonecrosis of the Jaw. Some of our learning objectives today will be the following. So what is it? No one's really heard of this except for the specialties. What medications are involved with this? So when you go through a patient's history, you can actually look through which medications may cause this. The pathophysiology. It's important that you understand the biochemistry or the physiology of it, because then you can educate your patients and you kind of know what medications are out there, or if they have an underlying disease, you kind of know how everything works. With everything, there is a classification system. This classification system allows you to talk to your specialist. It's not necessarily that you have to memorize this, but with each stage or each classification, this allows you to escalate care when necessary. Or if that patient comes to an oral maxillofacial surgeon, then we understand that there's a certain treatment algorithm with which each class. What is the treatment? And what are the risk factors? Now, I'm not going to spend an hour or 2 hours on this, which I could easily do, but this gives you a nice insight on what this is, and I'll give you some pointers at the end of what you can do on Monday. The other thing, too, is I'll finish up with a case report to kind of really bring all this together. So what exactly is this? So back in 2004, in the early 2000s, Dr. Marks, a world-renowned pathologist, not pathologist, but oral maxillofacial surgeon with an emphasis on all this, noticed that there were these non-healing cases of exposed bone of the oral cavity on patients that were treated with bisphosphonates. So in September 2004, Novartis, which is a huge manufacturing company or pharmaceutical company, actually changed the labels on their packagings, basically warning everyone of this potential osteonecrosis of the jaw. So in 2009, there was an update position paper on bisphosphonate-related osteonecrosis of the jaw. So a lot of people are familiar with MRONJ or bisphosphonate use causing this issue. In 2014, there's an update, and the reason why it's called MRONJ or medication-related osteonecrosis of the jaw is because they realized that there were other medications that caused this issue instead of bisphosphonates. That's something that I don't think a lot of people have picked up because this is such a new update. So the biggest thing is to distinguish this from other forms of delayed healing. So for instance, we have osteomyelitis, we have diabetes, and we all know that diabetes is a systemic issue that causes delayed healing. Osteomyelitis is a fancy word for inflammation of the bone. So this definition of MRONJ has been modified, and there are certain criteria that need to follow. So before we begin, these are not my cases. These are case reports that are online. However, I wanted you all to get an idea while I'm discussing this, what exactly does this look like? So again, to a general dentist who may not see this, this could just be non-healing from diabetes, or there's inflammation of the bone. However, when you dive into a patient's medical record, then you realize, oh my gosh, there's something more to this story. So again, these photos are there for you to kind of keep an idea of what's going on while I discuss everything before the case report. So for a patient to have MRONJ, there are 3 things that need to be present. So these are very important. So you have to have a current or previous treatment with an anti-resorptive or an anti-angiogenic agent. Basically, these are the 2 extra categories to this thing called MRONJ. So if the patient has no history of taking these medications, then theoretically it is not MRONJ or BRONJ, but it's another systemic issue or disease. The second thing is the exposed bone needs to be present for more than 8 weeks. Now granted, under my training, this was not necessarily the case where we said, okay, week 7 is no, then week 9 is yes. But this is a gauge. And then the most important thing is that there's no history of radiation to the jaws or metastatic disease to the jaw. So again, radiation treatment, we see a lot of squamous cell carcinoma of the oral cavity, and if a patient has radiation therapy, then this is a completely separate entity. So this is something for you all to really take note. So what are the medications? So essentially there are 3 types of medications. I'm including oral and IV under one umbrella. So we have bisphosphonates, we have the rank ligand inhibitors, and we have the anti-angiogenics. So again, before this 2014 update, I don't think people were aware that these 2 other categories of medications can actually cause this issue. So IV bisphosphonates, this is something that I think we're all more familiar with. So this is to manage cancer-related conditions. So you'll hear this term SRE, which is skeletal-related events. So all that is that you have a primary cancer that has now spread to the bone. So whether it's prostate cancer, lung cancer, breast cancer, you sometimes have lytic lesions and multiple myeloma. If that goes to the bone, then sometimes these patients are treated with IV bisphosphonates. IV meaning intravenous. Now, the FDA approved the management of IV bisphosphonates for osteoporosis. So for instance, we have a yearly infusion or injection of Reclast, or you have another injection that's administered every 3 months. So again, the FDA has approved these medications. Now, oral bisphosphonates. The biggest one is Fosamax. I think everyone has kind of heard of this. This comes in a 70 milligram tab. Again, this is approved for osteoporosis and osteopenia treatment. Now, the rank ligand inhibitors are a lot different. So the biggest one is Prolia. So this is for this is interesting. So this has been approved for osteoporosis, but that has gone to kind of a more severe form. The other one is Xgeva. Now you probably noticed that they have the same generic name. That's fine. It's not that this was a misspelling or anything. There are two separate drugs, but they're used differently. So Xgeva is used for metastatic bone disease. So if you see Prolia or Xgeva, a red alert needs to go off, and you need to say, uh-oh, I need to either talk to a specialist, the patient's oncologist, or really figure out what's going on. So this is the biggest thing that you guys need to take away. So if a patient is on bisphosphonates, the half-life of bisphosphonates is 10 to 12 years. That means if the patient stops their treatment, that medication is still in the skeletal matrix of the bone. Now with the rank ligand inhibitors, it does not bind to bone. So if the patient were to come off therapy, theoretically that drug should be out of the system in 6 months. Again, that's contrasted to bisphosphonates. Now anti-angiogenics are a little bit interesting. I just have one slide on this. Again, this lecture, it could easily be 1 hour, 2 hour, and actually a half day. Some of the medications are listed below. But basically, it has some efficacy in the treatment of GI tumors, renal cell carcinomas, and neuroendocrine tumors. So this is the biggest thing, pathophysiology. So one of the things, this is, everyone's kind of scared of the biochemistry, but this is pretty easy to figure out. And this is still a great debate in terms of what is actually happening. So there are 4 categories. Sometimes the inflammation and infection are under one umbrella. So you have osteoclast, angiogenesis, inflammation, and infection. So with inhibition of osteoclastic activity, we know that osteoclasts play a vital role in bone healing and skeletal remodeling. So if at any point the osteoclasts are inhibited in their activity, the bone turnover is quite different. So when you have increased remodeling rates in jaws, compared to normal jaws compared to osteonecrotic jaws, then you start to realize, oh, there could be actually a difference in terms of what's going on. So again, bisphosphonates is an osteoclastic inhibition. Also, what they've looked at are beagle dogs who have taken 3 years of daily oral bisphosphonates, and they looked at the histology of it, and they realized that there's a decreased intracortical bone turnover. So what that says is when you take these bisphosphonates, the cortical or bone remodeling or turnover has decreased. The other thing that we realized too is that osteonecrosis of the jaw primarily occurs in the alveolar bone of the maxilla and mandible. Inhibition of angiogenesis. So angiogenesis is a fancy word for basically vascular growth. So this is a process that basically differentiates endothelial cells to form new blood vessels. So, but this does require a signaling molecule called VEGF, or vascular endothelial growth factor. So this signaling promotes new blood vessel growth. So just to go back real quick, so when you have, so the anti-angiogenics, they affect this receptor, and so you have decreased blood flow, which we ultimately know is going to decrease the healing of the surrounding bone. Just real quick, osteonecrosis, again, is an interruption of vascular supply, or avascular necrosis. So this is, again, one of the hypotheses of what's going on with this MRONJ. So reclass is, I have the studies listed below. So reclass does demonstrate that there is a reduction in angiogenesis. Studies in cancer patients do support this by stating or documenting that there are decreased levels of this signaling molecule that's required for vascular growth. And then there's a lot of increased literature that supports that osteonecrosis of the jaw in patients are receiving these anti-angiogenic drugs. So this is all relatively new, and as you imagine, by adding these anti-angiogenics or rank ligand inhibitors, it's all kind of making sense, but there's still different theories of thought. So with inflammation and infection, both animal models demonstrate that inflammation and infection do induce osteonecrosis of the jaw. As you can imagine, if you have bacterial infection, if you have a dirty mouth, then this is a poor breeding ground for healing. The other thing too is the bacteria that they're finding. Again, I can't go into this because that's a whole nother hour or two of lecturing. But whenever we biopsy bone or tissue, we do send it to the microbiologist and the pathologist to get it looked at, and we're starting to figure out that certain bacteria are causing this. So let's go to the classification. The classification is it's quite simple, but it is subjective. So for instance, there is an at-risk category. So what this means, there's no apparent necrotic bone in patients who have been treated with either oral or IV bisphosphonates. So again, it doesn't have to be just bisphosphonates, it's just in general. So what this means is people who are walking around who will never come into your office, there is a level of risk, and this is what that category is. The second category is stage 0 or stage not. So what this means is there's no clinical evidence of exposed bone. However, there are non-specific findings. What does that mean? A patient may be symptomatic and or there are radiographic changes. So some of the radiographic changes that you would see is maybe some diffuse osteolytic changes within the alveolar bone, but you can't necessarily say it's because of this medication. This is why we're still at a low risk or an early stage. Stage 1. So stage 1 is where there is exposed bone. However, the patient's asymptomatic and there's no evidence of infection. Now you're probably thinking, how can someone have exposed bone and not be in pain? This happens all the time. You'll be surprised. Some of the worst cases that you see, the patient is completely asymptomatic, even though majority of their jaw may be exposed. So here's an example of this. Again, that's that case report online. This is not my clinical photo, but this is an excellent point of showing that you have an area of exposed bone on the right posterior mandibular alveolus. But if you look at the surrounding tissue, the tissue is pink. It's not purple. It's not congested. I don't suspect that there's any purulence. It looks pretty healthy. So this would be stage 1. Now stage 2 is you still have the exposed bone or a fistula that probes down to the bone. Now we start to have pain, erythema, with or without purulence. So this is what's interesting. Just because someone does not have pus or purulence does not mean they're not in stage 2. When the patient becomes symptomatic and you see areas of redness, then they get bumped to stage 2. So you guys are familiar with this case. This case is on the lingual side of the right posterior mandible. This is my clinical photo of a clinical patient we treated in residency. What's interesting here is you see the exposed area of necrotic bone. However, this is not the pain that this gentleman was experiencing. But as you can see, the surrounding tissue is not pink like stage 1 that I showed you earlier. It's purple. It's congested. It means that the venous drainage has been compromised. Now stage 3 is when you have pain, infection, in one of the following. So if the necrotic bone extends past the alveolar bone, for example, if on X-ray or CT scan, that diffuse osteolytic changes are going down to the inferior border, or you go to the ramus, or it extends to the sinus or the zygoma, then you're automatically in stage 3. Also, a lot of times we have patients, older ladies who are in their 70s, 80s that are edentulous. They have an atrophic mandible, and they have some sort of trauma that leads to this process, and all of a sudden you have a pathologic fracture. That's stage 3 immediately. Sometimes we see this where that infection process forms an extraoral fistula, automatic stage 3. You can get oral nasal or oral antral communication. And then kind of what I discussed earlier is that if the osteolytic process extends to the inferior border. So what's the treatment? Again, this is something that we can go at length, but I want to bring this to your attention. So if you do have to refer a patient to an oral surgeon or back to their oncologist, you need to be able to just have an idea of what the treatment would be. So the biggest thing here is the preservation quality of life. So these patients are in terrible pain. I mean, it is an awful process because you have exposed bone from something that could have been from a dental extraction, from a dental implant removal, or just trauma from biting on a fork. Anything that causes this type of pizza burn or paper cut inside the mouth or trauma can escalate this process. So the biggest thing, I believe, are 3 things. One is we got to educate, right? That's why we're doing this lecture, and that's why that I'm completely open to you all sending me emails or asking me questions, because this is kind of complicated and it's new, but it's not that complicated. You just need to have high alert. The other thing is we got to control the infection process so it doesn't go to a pathologic fracture or an extraoral fistula. And then the biggest thing is prevention. Again, I don't care who does dental implants. I don't care who does wisdom teeth. All I care about is if you're going to do that surgery, you need to know a patient's medical record, because if you do that and there are complications, then it's not fair to the patient that you can't treat that, but you did the procedure. I always look at it as, if this was my mom or if this was my grandparent, do they really need an extra dental implant, or do they really need wisdom teeth removed? No, let's step back and make sure that we do not put this patient at great harms, because once you see it, it is awful. So, at-risk category, like I said, these are the patients that are just walking around. So there's no treatment indicated. What we need is patient education. Stage 0 or stage not. So this is when we start to use pain medication and some conservative management of local factors. So we're not necessarily administering antibiotics yet, but what we're doing is, this is where the practitioners come in. We got to take care of caries and any type of periodontal disease. I know that may seem silly, but with these type of patients, they're just so delicate, and we need to take good care of them. So sometimes we have to lean on them to say, you got to get back here every 3 months, or you got to get back here every 6 months. I mean, we have to do this. And then pain medication. So whether that's Motrin, oxycodone, we try to lay off the chronic medications because this could be an issue down the road. Stage 1, again, patient education. Now, this is the most important thing. This is probably where a general practitioner will not step in, and that's fair, because you guys aren't used to, you're not exposed to this. But what we do as oral maxillofacial surgeons is we contact the oncologist. We then say, listen, we need to outweigh the risks and the benefits of maintaining this bisphosphonate or rank ligand inhibitor or anti-angiogenic medication. We need to figure out, is it worth this patient continuing on this therapy, or can we back off and really attack this problem? The other thing that we start is what's called Paradex rinse, or chlorhexidine gluconate, which is an antibacterial mouth rinse. We do that on everybody at this stage. The other thing is clinical follow-up. These patients have to understand that they're going to see us a lot. Whether they drive 6 hours or 20 minutes, you need to let them know we're going to be pals. Stage 2. This is a symptomatic treatment with oral antibiotics. So this is where we need to step in and start taking care of the infection process. Then we need to start talking about pain. So again, Motrin, oxycodone, narcotics. And then this is where we may need to step in and debride the area. Now stage 3 is where we don't have a choice, and it really forces our hand to do a surgical treatment. So we do the antibacterial mouth rinse. We're doing antibiotic therapy. Now sometimes you can do antibiotic therapy through mouth or IV. Again, that just depends. And then this is where we probably need to take them to the operating room and do a more thorough surgical debridement and possible resection. Risk factors. So the biggest thing is the location. About 73% of the time it happens in the mandible, and only about 22% of the time in the maxilla, and less than 5% in both jaws. The reason why the mandible is more susceptible is because it has increased cortical bone, like I talked about before. The other thing that you all are used to, dentures. So if you think about it, dentures constantly cause trauma on the alveolus, right, the gum tissue. So as soon as you start to rub that raw, that's trauma, and now you have delayed healing process. So we have associated with an increased risk among cancer patients exposed to these medications. And there was a study done of over 1,600 cancer patients that they had a 2-fold increase of osteonecrosis of the jaw when they were on these medications. Oral disease. I think we can all understand this, is that if a patient is on these medications and they are periodontally jeopardized, or their teeth are hopeless or questionable, this is an issue. This is where we are very careful of extracting teeth. We may even talk to a general dentist or an endodontist to cut the crowns off and to do root canals to leave the roots in, because we don't want to cause any trauma. Again, this section we can really dive in, and I would love to get your all's feedback for a longer lecture as well. Now this is the case report, and I'm going to finish up with this. Again, there's just so much to cover, but I think these case reports take it home. So this patient is 74 years of age, and he was referred to us by a maxillofacial prosthodontist within the hospital system for the exposed bone on the right mandible. His chief complaint: it's been difficult to eat without discomfort, and Advil has helped me with the relief. So we got to look at his past medical history. What on earth is going on here? Okay, hypertension, that's normal for a 74-year-old. Hyperlipidemia, that's normal, it's fine. Atrial fibrillation, that's starting to become more prevalent than we'd like, but it is manageable. And then, here we go, melanoma. So now we got to dive. So if you're a general practitioner and he says, oh yeah, I had some history of melanoma on my forearm, well, that's a red flag. We don't just say, oh, well, let's let's start extracting teeth and placing implants. No, we gotta sit. Okay, hold on. Now we gotta look at what medications this patient's been on. So, quickly, melanoma of the left forearm, status post-shave biopsy. So they were going to do a lymph node biopsy, which is a more definitive treatment. However, the case was canceled because of thrombocytopenia. Thrombocytopenia is a fancy word for you don't have enough platelets. So a lot of times if someone doesn't have a lot of platelets, we won't do surgery because it's not in their best interest. Also, atrial fibrillation. He must have had an issue either at consult or during the shave biopsy. So again, they could not do the bigger surgery to attack the cancer because of all this. So they did what's called a wide local excision. So all they're doing is they're scooping out the melanoma of the forearm. All right, 2 years goes by. He now has a swollen left axilla or armpit. Well, what has now happened is they took a biopsy of the left axilla and realized that the cancer from the forearm has now spread to his axilla. So now this is very serious. Okay, months later, he gets a brain MRI that shows metastasis of the melanoma coming from the forearm, axilla, now the brain. Now we go to restaging. So now he has hypermetabolic activity, which means this cancerous process has gotten worse. It's gotten to his left axilla lymph nodes and his left humerus. So what they do is they start radiation therapy and they start Xgeva. This is where we need to be careful, because if we didn't do this research on his melanoma, we would have missed all of this. But this is where your due diligence is. So it doesn't matter if you're going to refer a patient to an oral surgeon for extractions. You gotta know a patient's medical history if you're going to treat them. And I think that's understandable. That's why we went into dentistry and medicine. Medications. Okay. Aspirin, not a big deal. Mobic, okay. Lisinopril, lovastatin, all fine. However, we gotta resort back to Xgeva. So again, Xgeva is a human immunoglobulin G2 monoclonal antibody that binds to the human Renkel ligand receptor. This is what stops the process of bone remodeling. And again, this does not have an affinity for the bone matrix. So if we stop, the half-life is basically 6 months, whereas if this patient was on a bisphosphonate, it would be 10 to 12 years. So this is not complicated, but again, if you're not exposed to it, it's tough. And the only reason why I can speak of this is because we experienced this in residency. So these are the photos. This is what was on the event poster. So what we can see here is the necrotic bone. What these arrows are showing anterior to that necrotic bone are the fistulas. We could actually express some purulence, as you can see in the center photo here. Now what you need to understand is this is the fascinating process of this. So on his lingual left mandible, where the tori is, you can see it's nice and pink, good blood flow, it's healthy. What's crazy is on his right side, you can see how the tissue's purple, it's congested. This is a telltale sign that something's going on. People talk about this purple tissue. Something is going underneath that tissue. So nothing's complete without a Panorex and an orthopanogram. This is a high quality orthopanogram. This is diagnostic with the condyles and the fossa. The condyles are nice and rounded in morphology. We don't really see any osteolytic processes that suggest otherwise. This is normal for a 75-year-old. So now we start to look at his dentition. So he's had some restorative work. That's fine. Who hasn't in their 70s? But if we start to look of his right posterior mandible, at tooth number 31, we start to, or the middle arrow, we start to see there's bone loss, there's furcation involvement. So now we got to realize is this infection and inflammation process causing bone loss in his dentition? So if you all were in front of me, I would raise my hand and say, who knows the stage of this MRONJ? Well, it's stage 2. And I go back to this photo. He's somewhat in pain. You can clearly see the erythema of the tissue. And in this case, we do have purulence or pus. Now it's not stage 3, because it does not extend outside of the alveolar bone. So now we go to our treatment of what stage 2 is. So we start oral antibiotics, which is typically like a penicillin or amoxicillin. We do the oral antibiotic mouth rinse. What you probably noticed is, for instance, a lot of the plaque or that green film on the teeth is actually from the mouth rinse. It's not that he's doing a bad job brushing. It's just that stuff stains your teeth, and that's on the bottle. Pain control, and then we need to debride. We need to get rid of this infection process. So what did we do? So what we did is that we did a bilateral mandibular tori removal with a debridement of the right lingual mandible. The reason why we did tori removal is because if you think about it, whenever you're biting on a fork or a sandwich or a pizza crust, your tori are more susceptible to trauma, and that's what causes MRONJ. So what I just said in our findings is we found a lot of mobile teeth, class 1, class 2 mobility, which means he still has nice surrounding bone. However, when we did debride, we did it all the way down to cancellous mandibular bone. So you gotta make sure you debride this area to bleeding bone so you know you're gonna have a healing process. So we took some microbiology, as you see here, not really helpful in terms of the anaerobic cultures. We have mixed flora. It doesn't really give us specifics. The second thing we did was aerobic. So heavy growth of mixed gram-negative and gram-positive organisms, great. That's normal oral flora. Again, not really helpful in terms of specificity. Then we always do a fungus just to make sure to rule out any type of mucormycosis or anything going on in that sense. So no fungus. Then we did pathology. The pathology doesn't really help in this standpoint because all it's telling us is that we have dead bone, which we kind of knew to begin with. However, you always got to do that just in case there's a different infectious process going on. So the next slide that I'm going to talk about is, excuse me, sorry about that. So the next slide is this. This patient has gone through this oral pain after surviving cancer. So what on earth causes? Because I haven't told you yet. It's unbelievable, unbelievable. I was eating a corn chip a couple weeks ago that cut the inside of my lower jaw, and it was taking a while to heal. So this is how crazy. This guy has survived cancer, brain metastasis and everything, eating snacks just like all of us. Because he has the tori, he bites into a chip, causes that nick or that paper cut on his tongue, and now his life has changed drastically. So as I'm finishing up, again, I have several cases. I had one that just got accepted on a national level that I would love to share at another time, whether that's in person at a conference or another webinar. This is something that can easily be talked about over an hour or two. So this is what I want to give to you all who are not oral maxillofacial surgeons, because we're in this together. We're here to spread knowledge through Implant Compare, and I'm just honored to be able to share this with you all and hopefully get to meet you in person. So what are the things that we can do today to step towards to correct this direction? So what are you going to take on Monday? Or if you work weekends, that's great too. All right, key. You gotta be thorough with your past medical history. One of my pet peeves are people or providers who do dentistry or medicine, but they don't do the due diligence to be able to have the gift to do these procedures. We're doing all these amazing procedures, soft tissue, dental rehabilitation. However, it is our duty under our specialty to take note that these patients may have an issue. That is that is what we need to do before we can have the gift of doing these surgeries. And I think everyone can agree with that. So questions, real quick. Instead of saying, are you on bisphosphonates? Are you on anti-angiogenics? Are you on rank ligand inhibitors? No patient is going to understand that. The way I proceed is, are you on any bone strengthening medication for osteoporosis, osteopenia, metastasis? Have you had a history of prostate cancer? These are all buzzwords that may get the patient to say, oh yeah, I see an oncologist. Boom. Go call the oncologist, and then what you can do is call your maxillofacial surgeon for clarity. Now, all you oral maxillofacial surgeons out there, Don't be giving general dentists and other providers, a lip or ignore them because they're asking you these simple questions. They are looking to us to provide them because they were not exposed to this in dental school. So we need to help them up. Dental providers. If you have an oral maxillofacial surgeon that's not willing to talk to you, email me, call me, contact me on social media. It is our duty to pass this information on to you. So you should not feel bad calling us to ask. If you're doing that, you're making me happy. If you're not doing that, you're scaring me. The other thing is you got to get knowledgeable of knowing the current position papers. I actually give these position papers to my patients. Now, they may only understand 2% of what's going on, but you have no idea how many patients love the fact that I'm giving this to them. Educate your patients. This is the website that we can use to give our patients that position paper. Everyone, Implant Compare, wherever you are. I know I have people in Australia. I think it's like 3 a.m. there. Thank you so much for this opportunity. I hope to meet everyone in person. These are the references. You can go to my website, drmattkoepke.com. You can email me, social media, Facebook me, whatever. Please ask me questions, and hopefully I can get to everything. Thank you so much. You guys were awesome, and I can't wait to do this again. Thank you.